I'm going to start the discussion of eosinophilic esophagitis with an actual case. This is a 26-year-old man who presents with intermittent dysphagia to solids only since the age of 15. He has had 2 past episodes of food impaction. He denies heartburn. He has no acid regurgitation and no past ingestion of any corrosive agent. You obtain an X-ray and it shows this rippled esophagus, as well as I can describe it, with a narrow caliber. And those ripples are created by subtle esophageal rings. Next, you obtain an endoscopy and you see the succession of concentric firm rings throughout the entire esophagus. So your observation is that the esophagus is narrow, that there are multiple rings. You take multiple biopsies and you go ahead and dilate the esophagus using Savory dilators from 12 to 15 millimeters. And post-dilation, you take a look. On the left, you have the guide wire still in place. And on the right, after dilation, you notice that you have produced what we would call a superficial laceration or a tear. The patient goes to the recovery area and pretty soon the nurses call you to tell you that he has developed severe chest pain. You proceed to have chest pain yourself because you're worried about perforation, and you send the patient to X-ray. Fortunately, a gastrograph in swallow shows no perforation. So this is a typical case of what I would refer to as a florid case of eosinophilic esophagitis, which I will refer to from here on as EOE because it's easier to pronounce. So what's the definition of EOE? The most accepted definition by consensus now is that it's a chronic immune-mediated disorder of the esophagus with esophageal symptoms and intense esophageal eosinophilia defined as 15 or more eosinophils per high power field in the absence of other causes of eosinophilia. Now, it's a lengthy definition and it has at least 3 major components. It's immune-mediated, it has esophageal symptoms, and we won't define them any further because they vary from patient to patient. And there is a histologic component to it, a certain number of eosinophils, but other causes of eosinophilias have been ruled out. Why is that? Because there are, as the next slide shows, multiple causes for eosinophilia. Now, I will dispense with parasites and fungi and IBD because they occur in a clinical context in which you're not going to be thinking of EOE. Really, the differential diagnosis is going to concentrate mostly on 2, GERD and EOE. Now, occasionally, particularly in children, the entity of eosinophilic gastroenteritis will come up. But again, this is in a context of diarrhea, abdominal pain, other symptoms. And so for practical purposes, we're going to concentrate on the relationship between GERD and EOE. Now, what's the prevalence of the disease?
The issue I was having, and this goes back about 10 years ago, I was having inflammation of the esophagus. When your esophagus gets inflamed, you can't swallow. And that's why I ended up in the emergency room. At the time, the doctors were familiar with this condition called eosinophilic esophagitis. My general practitioner was familiar with some of the work that Dr. Fernandez Becker had done and sort of pointed me to Stanford. The first day I was there, It was clear that this was an area that she was familiar with.
Every time I meet a new patient, it's a great journey, to be honest, because I get to know them. I have patients that I've followed for years, and they feel like they're family.
I feel like she cares about me personally as a patient. When I'm there, I have her undivided attention. She knows me, she knows my history, she remembers it all.
A lot of times, these patients, we're the fourth or fifth gastroenterologist that they've seen. They don't come to us completely naive. And I have a very frank discussion with them about, this is what's happened before, this is why I think you're having these symptoms, this is the plan for us to sort it out. In David's case, he had a very good response to medications that treat acid reflux.
And it turns out we were able to manage the condition. I think that's really been a lot of the success that we've had, is sort of the way we work together.
I'm Dr. Jeffrey Alexander from the Mayo Clinic Rochester, Minnesota campus. I work in the eosinophilic esophagitis clinic along with my colleague David Katska and a group of allergists, dietitians, and esophageal nurses in the management of eosinophilic esophagitis. This is a disease that is defined by the presence of eosinophils, which are white blood cells in the lining of the esophagus. Really didn't know much about this disease and really didn't start looking for it routinely until maybe 2000. And it appears to be increasing in frequency significantly in our society over the past decade. Now, some of this is because the disease was there and we really didn't look for it. But I think clearly there's been an increase in incidence beyond that over the last decade, which has been seen with other allergic diseases as well. This is a disease that in children presents with a multitude of symptoms, but in adults it presents with primarily solid food sticking when they swallow, so-called dysphagia. These are people that notice when they eat bread, meat, dry rice, it sticks. They have to wash it down. Sometimes they even have to regurgitate or vomit up the food. And occasionally they end up in the emergency room having the piece of meat removed by medical professionals. The natural history of this disease is really uncertain. It appears that it persists long term. Generally persistent symptom is that of food sticking. Does not lead to cancer, does not lead to debilitating illness, does not spread to other organs.
EOE treatment can be really complex. Although we say it's allergen driven, sometimes it's really hard to detect what the actual allergens are that are causing it. We think of allergy in the sense that you can do a blood test and find an antibody that's triggering an allergic response. But in this disorder, you don't always have that correlation. It is not classically triggered by those same antibodies that you think of someone having an allergic reaction that would get difficulty breathing or hives on their body. So treatment really can revolve around a few different areas. Number one could be diet. So even though we don't know specifically all the time what food or foods are causing the disease, we may try different diet eliminations of most common allergens that are known to affect children, to eliminate them completely from the diet and see if that helps. On the other hand, there may be people who test positive on allergen testing for hundreds of foods. And in those situations, you may opt to do what's called an elemental diet, meaning you remove all of the food proteins from the diet and you supplement them with a specific type of formula. Once you do some intervention, you may need to then go back and do an endoscopy to look for response in this inflammation. Medication treatment options are also available for EOE. Topical steroids are medications that traditionally were actually used for asthmatics. They were inhaled steroids. We use them a little differently, and instead of breathing them in, you actually swallow the medications, or you mix them in a little bit of a slurry and you take it down on a spoon in order to coat the esophagus, which is the inflamed area, and give it some relief that way. So it decreases the inflammation. They're known to work very well. But when we think about this disorder, we also have to take in mind that this is something that's considered chronic. So EOE is a chronic disorder, which means it's lifelong. And we discussed how this may be a fairly new diagnosis. So the things that are still unknown are what are the long-term effects of these type of treatment options. Topical steroids aren't the only medical therapy, but a lot of the time some significant steroids, so for example prednisone, is really reserved for when you have significant disease that may be a hospitalized child or someone who has a distinct complication from the disorder and requires it. Lastly, there's endoscopic interventions. So as a potential complication from EOE, the esophagus can become rigid or narrowed and needs to be opened up. So in certain situations where it may not respond to medical treatment, you may have to have an endoscopic intervention to expand the esophagus back to its normal size. I believe that here with the CADC and New York Presbyterian that we really care for the individual patient. We pay attention to their needs. We look at the most cutting-edge research in order to give our patients the best possible care. And that's really what we strive for on a day-to-day basis.